Does menopause mean you're going to gain weight and suffer?
There's a lot more information about menopause and things we can do to help ourselves. Today we talk to Emily, a specialist in all things menopause.
As a health coach and a wellness coach, we ask the questions so you get the answers. Let's get started as we ask.
Wait, what? So Emily Sadri is joining us today. I'm so excited to talk to her. How are you, Kamna?
I'm good. How are you?
Good. Are you excited too?
I am excited. I have so many questions.
Me too. Okay, well, Emily Sadri is a board-certified women's health nurse practitioner, certified nurse midwife, and hormone expert who founded Aurelia Health, a modern telehealth company that serves women navigating perimenopause and menopause. Emily's area of expertise includes metabolic health, precision hormone care, and longevity medicine, which so many questions right there. Anyway, she resides in the Midwest with her husband, 4 children, and 2 dogs. A lot of questions right there about 4 children as well. So I am just a bucket full of questions right now.
Well,
Yeah,
I'm
you
so
don't
excited
even
to be
look-
here.
You don't even look old enough to have 4 children. And
You're so nice. It's because I have optimized HRT. But
What does that mean? What does that mean?
well, what does that mean? Having optimized HRT to me means that you've optimized the dose based on your specific body's needs and your
HRT is hormone replacement therapy.
hormone replacement therapy. Exactly. Yep.
Wait, so you take hormone replacement therapy?
I do.
Oh. How did you know to take that? I'm already starting off.
No, I love the question. So, I left practice. I left conventional medicine about 5 years ago. In the height of the pandemic, I actually gave birth almost exactly 5 years ago to my 4th baby. And I left and I resigned 2 days before my maternity leave ended. And I'd been studying a lot of functional and integrative medicine in my last few years of working in the conventional space. I was a midwife. So I was doing primary care, women's health care, birth control, period management, and I was delivering babies. And I loved the work, but it was almost impossible to not be in a constant state of burnout with the sort of level of work that I was doing. And so I was really interested always in integrative approaches to health. I feel like midwifery, the way that we treated birth, we really understood and supported physiology. But when it came to GYN management, like of heavy periods or menopause, the sort of algorithms that we were handed in school and in practice were very generic, very OBGYN based, not creative, not holistic. And it felt like a mismatch for me in the profession. So I started studying functional medicine. And when I resigned, I thought, I'd love to join a practice. I'd love to, continue to work in this way. And the universe had it that no one wanted to hire me to do that. Just a good thing, because it pushed me to start my own practice. And so I did. I opened my own practice in 2021 in March. And I started out just doing functional medicine. I attracted a lot of women with women's health issues, GYN issues, because of my background. But I was really practicing what I'd learned, which was start with the gut, eat a whole diet, clean the gut, work on detox, dampen autoimmunity, the kind of basic fundamentals of functional medicine. And what I found was that so many of my patients were women in their 40s and 50s because our health really takes a turn at that age. And while they got a little better with what I knew, they weren't really getting all the way better. Like there was just something missing. And it kind of felt like I was putting them on this endless cycle of, you're still not good enough. Like women would get in this mindset of like going from a slim fast diet culture of like restriction to a functional medicine diet culture of elimination diets was just this, just didn't feel right. It felt like it can't possibly be that they're just not doing it well enough. There has to be something missing. And so while I was using hormone replacement therapy, I was doing kind of what a lot of people were doing, which was very low dose. I was using Biest, which is 80% estriol and only 20% estradiol. Estriol is like a weak form of estrogen that I think on the heels of the Women's Health Initiative and the sort of 20-year hiatus that we had from really practicing good hormone replacement therapy was considered safer. But really, it's just less effective. And so I would get some modification of symptoms, but not like your health wasn't coming back like a tidal wave, which is what I was really looking for.
Okay, wait, I need to stop you for 1 second because I'm super confused already.
Okay.
So you're saying that women, once they start getting 40, 50, and they're just not, they feel like gross and yucky, that's when you should start a hormone replacement therapy, or that's when you personally did, or?
Yeah, I started HRT around 41, but I think it's really individualized per each person. Should is a strong word I think
Oh.
that I don't believe in HRT in a silo. So I don't believe that like if you're feeling badly, you should just start HRT, especially not a standard regimen. And I think that, you know, with the advent of all of these telehealth companies that are popping up where you can just kind of go online, fill out a questionnaire and get estrogen shipped to your door, it gives people the impression that like it is a one-trick pony, that all you need is like this one thing. And it really is multifaceted. I believe that we should be testing. I believe that when we're looking at a woman's health in midlife, we need to look at all of the areas of the body that are impacted by loss of hormones, like cholesterol, like nutrients, like inflammation, autoimmune markers. We shouldn't just be looking at hormones or just treating symptoms. I really think of it as like optimizing hormones, replacing hormones can be one part of optimizing the system. And I think it's a very critical part. But again, it doesn't work in a silo. You have to really look at the whole picture. So
We
should
just
start
generally-
HRT. What's that?
So we just generally lose hormones as we're starting to get older. Our body
Correct.
just
I mean-
isn't producing them.
Yeah, really, you're losing hormones from birth. You know, I mean, like you know, our ovaries are always aging,
Okay.
right from the very beginning. So but after 35, they start to age much faster. We call this ovarian senescence. It's the process of like cellular death, essentially, and the ovaries age faster than the rest of the body. We have grandmothers in this, you know, in our species. Not every species has grandmothers, meaning we don't have women who go through menopause or females that go through menopause in every animal species. That would be like a whole other podcast for another time of sort of like what's the physiologic purpose of menopause. But you know, from age 35, you hear about the fact that people are less fertile, right? People know this kind of idea of like once you're 35, it's harder to get pregnant because the number of healthy follicles that you have is declining, right? In the ovaries, follicles being like what become an egg, right? And it's actually those follicles in the ovaries and the ovaries themselves that are producing estrogen. Right. So as the ovaries age and all the cells in the makeup of the ovaries age, right, progesterone declines, estrogen declines, testosterone declines somewhat, although the adrenal glands also make testosterone. So this is a phenomenon that's happening really from, you know, even 25, 30. It's just that it starts to happen exponentially after 35, that hormones are declining. And that has systemic effects on the whole body, right? It usually shows up first in the brain with mood and anxiety changes, sleep changes, motivation, brain clarity, forgetfulness, things like that. And this we talked about that often.
If is estrogen such an important thing, if it's so important for our general health, why biologically, why would we not have, are we just supposed to keel over after menopause happens? Is that what's supposed to go on? Or what's the purpose of it decreasing and then causing so many problems for us as women?
Yeah, I mean, if you think about it, 120 years ago, the life expectancy of women was late 40s.
Yeah.
Right. So like it wasn't an issue. It's a modern health issue, right? It's an issue of now that we've solved for, you know, horrible infections, right? We have antibiotics, we have surgery, we have things that can stop kind of all the reasons why people used to die younger. Now we're dealing with like, how do you manage chronic health and chronic disease? And so people are living longer, but they're living, as you both know, really unhealthily, right?
Right.
With a massive increase in chronic disease, and the loss of estrogen certainly precipitates that for women, accelerates that. So why? I don't know. It's a great question. You know, and the people kind of are puzzled. And, you know, when I was in midwifery school, I was very clear on the fact that I was never going to prescribe hormones because remember in the early 2000s, they were bad. I was going to prescribe herbs. I was going to wear Eileen Fisher clothes and Birkenstocks with fancy wool socks. And like, I had my identity like very firmly sealed and I was never going to prescribe hormones. But I didn't understand, right? At the time, I was so committed to sort of a natural approach and supporting physiology. And there are plenty of people out there who will say, menopause is a natural process. Why would you intervene? You can choose that for sure, but it's a choice, right? If you don't intervene, you know, are going to accelerate vascular aging, right? Your arterial stiffening will accelerate your risk of cardiometabolic disease. You'll accelerate your risk of Alzheimer's disease. You'll accelerate your risk of osteoporosis. So it's really just a choice.
Okay, I want to start at the beginning because I already have like 1,000 questions and I want to make sure that I'm focused. So if a woman, I mean, we're going to take an average person. I know this doesn't apply to everyone, but we're just taking an average image of a person. A woman in her late 30s, 40s, she's starting to experience some symptoms. What does those symptoms look like?
Yeah,
of
no, that's a great
perimenopause?
example too, late 30s, early 40s, because I think because menopause and perimenopause are getting so much attention, everyone over the age of 30 who has anything feel wrong with them are like, I must be in perimenopause. And,
Yeah.
you know, while hormones are declining, like there are so many things that we need to look at, right? So if someone comes to me and they're, say, 39 years old, and we have this all the time in practice, we're not just going to look at, you know, the pattern of her cycles and kind of the velocity of her estrogen peak before ovulation and things like that that indicate to us sort of ovarian sufficiency. That's a term that I like to use versus like, are you in perimenopause? I like to think, do you have ovarian insufficiency? Because that can happen really at any age, especially in women with PCOS, right? There's estrogen insufficiency in PCOS and other disorders. So we're going to really look at her thyroid function, right? Make sure that her thyroid looks really good, T4 and T3, even looking at sort of stress patterns in the thyroid, like reverse T3, look at her DHEA, adrenal sufficiency, et cetera. We're going to look at her blood sugar, right? Because that can mimic patterns of perimenopause, and also really erratic blood sugar can sort of worsen the communication between the brain and the ovaries and worsen overall hormone secretion and hormone patterning, right? So there's a lot of lifestyle things that could be kind of accelerating a picture that looks like perimenopause, but we can avert a lot of those things by intervening. We don't necessarily need to use HRT, right, in that woman. Maybe we do, right? There's certainly case scenarios where I have or used it for a short time while we worked on some of those other root causes. But those are the primary things really at any age that I'm going to look at. I'm going to look at micronutrients, especially things like B12 and vitamin D, magnesium, things that support phase 1 and 2 liver detoxification, things that support neurotransmitter function and formation. So how do we make serotonin, norepinephrine, dopamine? We want to really look at the whole picture. We want to look at iron and ferritin, folate, et cetera. We want to look at thyroid. We want to look at blood sugar and metabolic markers and inflammation and all of those things and really work on the whole picture. So a lot of times if you optimize all of that, then what we like to call the HPO axis, which stands for hypothalamic pituitary, the two glands in the brain that sort of dictate ovarian function. So how your ovaries know when to ovulate, when to release a lot of estrogen. That whole system and circuitry works better when everything else is in a good place. Now, there's a critical tipping point, right? Where even the healthiest person who's optimizing all of those other things, who has an optimal B12 level, who has an optimized thyroid, there's a tipping point where like, it doesn't matter how healthy you are, right? You may be even only be experiencing mild symptoms, but it's still worthwhile to investigate what state of ovarian sufficiency or insufficiency you're in.
And there's not just a test that you can be like, boom, here's how your ovaries are functioning.
Yeah, unfortunately, no. I mean, most physicians or providers in a conventional setting will run something called an FSH and LH. Those stand for follicle stimulating hormone and luteinizing hormone. They're brain hormones. So it's akin to looking at just a TSH for thyroid. And those can tell you roughly if you're in full menopause. So they'll be extremely elevated in the 70s, 80s, 90s, over 20, and they'll stay elevated if you're fully in menopause, meaning the brain is kind of screaming at the ovaries, like, please release estrogen, but like nothing's happening. That is a really bad marker of sort of where you are if you're thinking up through the lens of ovarian sufficiency, meaning how good of a job are the ovaries doing of releasing adequate levels of estrogen in the right pattern, the right timing, right? It's not just about the presence or absence of it. It's like, are you still cycling? Is there still a cycle happening? Or are you having 40-day cycles? Is it taking you a really long time to ovulate? And then once you ovulate, are you only really secreting estrogen for 10 days or so? So we try to, in a cycling woman, measure estrogen and progesterone about 7 days before her expected period. That's one way, but again, not a full picture because you might look okay from a blood level on that day, but before ovulation, things really don't look good. So we also use things like home urine monitoring. There are two monitors. One's called a Mira monitor, and other's called the Anito. I really like those. They're much more affordable than sort of the like 30-day tests that you can do with companies like Dutch, which are also great, but that's a one-time thing and it's more expensive than just buying the monitor. And with the monitor, you can monitor ongoing. So again, not perfect, but can show you like, oh, it looks like from the day of your period until, you're not ovulating until day 20. And it's like, you're living in this area where your estrogen's in like the 50s for days on end. And isn't it interesting that you're also having vaginal symptoms during that time? And you're also having more brain fog and you're also not sleeping. You catch my drift? Like it takes some investigation. It's not very straightforward, unfortunately.
where I'd like to go is I'd like to take there's several things you mentioned and sort of talk about those specifically
Sure.
because there's a lot with this topic. And I think we could cover hours and hours talking about this. The place I would really like to start is the weight gain that happens in menopause. If you could talk to that, and then maybe what can we do as women to sort of combat that or even prevent that from happening?
Yeah. Yeah, that's a great
Okay.
question. And
Wait, before we move on, I just want to say I'm very sad right now because I feel so stupid on my own body.
please don't
I
feel that
do.
way.
No, nobody's making me feel that way. But I feel like, how am I 45 years old and I didn't know any of this? Like,
Mhm.
there's a missing gap here. Like, my regular doctor, my OBGYN, nobody has ever said to me, like, this is what's like, you know what I mean? Like, everything you're
Yeah.
talking is brand new to me. And that's sad that I don't, that it's new to me.
Yeah. I mean,
Like,
I have
there's
to
a
say,
big missing gap here that I'm,
huge. Well, part of it is that, when I was in school in the early 2000s, the hormones were just bad, right? They were just in the bucket of bad. So we didn't learn anything.
Sure.
All we learned about perimenopause and menopause was that you have to start screening for lipid issues and blood pressure. You start giving women baby aspirin and calcium supplements and magnesium. Like, that's what we learned. We learned like how to mitigate what were downstream effects of hormone loss, but nobody ever talked about them as related to loss of hormones, which is really unfortunate because what that really tells you is that our education is so driven by the treatments we're allowed to give or the treatments that are within our purview. So we actually had a whole generation of people that were not educated on adequate physiology because there was no drug that solved the problem. Does that make sense?
Yeah.
So it's a big problem. And don't feel bad because, when I started my practice 5 years ago, 4 years ago, 4.5 years ago, I had to learn a lot of this stuff. I learned by trial and error because I was working with women, ages. I was like, all these things, like you could take all the supplements in the world and you could have the perfect diet, but something still doesn't feel right. Like what was missing? Because even my functional medicine training was really devoid of good hormone training. It was like on the conventional side, hormones were just bad. So we were taught to give antidepressants. That was like the first line treatment when I was in school for any hormonal issue was antidepressants. And on the functional side, we were taught to support the liver and to give herbs and, that it was an estrogen dominance issue, which is a whole other thing. And so it was like both sides really had it wrong and both sides demonized estrogen. And there's a lot of that lingering still on both sides. I mean, this is probably why, social media is so confusing to people because they go on and they just hear a trillion million different things. But at the very fundamental level, I think it's most important, and I learned this from being a midwife, is like if we educate people on their physiology, then they will know. Women inherently know, like, what's the best course for them? What's the best way for them to manage the reality of what's changing physiologically in their body?
And also, I think women, when they talk about their issues or they complain or they tell their doctor, I feel like in general, there's always the exception, but we're dismissed. Like, this is normal. Don't worry about it. Here's a pill or here's
you're
a
getting
medication.
older. Of course,
Think about those doctors and like their quality of life, right? I think about all of the, very kind OBGYNs and physicians I've worked with over the years. They're burnt out. They're overextended. They're also experiencing perimenopause and menopause and don't necessarily know what to do. We have a large proportion of our patients are physicians who come to us and are like, I don't really know what this is. Like, how do I manage this? I had an OBGYN come to me and say, what is perimenopause? Like, what is happening? They don't know. So like, they're doing the best that they can with the limited tools that they have.
Right.
And there are a few big voices out there who are trying to change that for us. But I think, unfortunately, Gen Xers are, we're the ones taking up the torch. Millennials will have it a lot easier because we will have done a lot of the work for them. But this is a systemic issue for women and for providers.
Gosh, it's so okay. Anyway, sorry. Let's talk about weight loss because I need that too.
Yeah, absolutely. Yeah. So this is probably one of the number one reasons people come to us as well. I think women have a sort of intuition that something with their hormones is driving their weight gain because they know that they haven't changed their habits, but their body is changing. And we know that on average, women will gain about 1.5 pounds per year starting at age 40.
Okay, I got to write that down because then I got to do the math later.
Which is significant.
1.5 pounds a year.
And that's just average, right? So there are going to be many women that fall on different sides of that spectrum. And this, applies to active women, non-active women. I'm sure if you're sedentary and have a poor diet, it can accelerate a lot faster. But this is really maddening, especially because I think women, unfortunately, for better or worse, from my experience, tend to kind of have a number in their head. We have this way of kind of looking back and we're like, well, before I got married, or like when I graduated college, like I was this weight and I was so happy at that weight, or I was this weight, right? So I don't think that's a really helpful mindset, but for better or worse, you probably heard stories, or you probably experienced this yourself. Like a couple will come to me and they'll be like, we both decided to like go like do Whole30 or go gluten-free, dairy-free. And he lost 15 pounds and I didn't, nothing happened.
Yes.
You know, it's like maddening because we also get attached as women to like what worked before, but women can't, because the loss of estrogen really is accelerating inflammation, metabolic decline in many different ways. Is that the loss of estrogen will encourage more visceral fat deposition. So women will start to gain weight and their bodies redistributes fat. Their belly is getting bigger. And this is directly related to the loss of estrogen. They will start to have increasing cholesterol just because of the way that estrogen acts on the liver and the way that estrogen regulates different receptors. It decreases the way that we absorb and sort of circulate out LDL. So your sort of quote unquote bad cholesterol will just start to rise again with no change. And this can be so frustrating because your doctor will just say like, oh, you got to really work on your cholesterol. Like you better stop eating eggs and stop eating saturated fat, or I'm going to have to put you on a statin. But they won't mention the fact that this is directly correlated to your hormones. And we see people's cholesterol completely resolve when we start them on hormone replacement therapy.
Really?
It's incredible. And it blows my mind that even functional medicine people are not talking about this connection. There's a very popular functional medicine platform where you can get like a huge panel of labs done.
Yes.
And so I have a lot of patients come to me having gotten these labs done, and it'll say, your labs show that you're in menopause. And then it'll say, oh, you have metabolic issues, and your LDL is high and your HDL is low and your triglycerides are messed up. You should take berberine and you should take omega-3s, but never make the connection, which I honestly think is malpractice. I think it's so wrong when we know the science is there that explains that estrogen is so critical for the regulation of LDL and HDL and triglycerides and inflammation and CRP and all of these trends that we see in women's labs as they age, but we're not telling them that. Doesn't mean that you have to go on HRT, but you deserve to understand that connection. So there's also what I have seen though, which is so interesting, is, you know, because we have the privilege of doing complex precision HRT with younger women as well as older women. So we will work with women who have premature ovarian insufficiency, who are like in their 20s or 30s and have zero hormones. Like they look like they're in menopause. And there's, you know, lots of reasons why that can happen. Irrelevant for today, but we also work with women with PCOS who never ovulate and aren't cycling, and their estrogen again looks like a menopausal woman. And as part of the way that we are repairing their body and helping them to get better, we may start them on what we call physiologic HRT, or sort of a rhythmic HRT method at a young age. And this is really interesting. I'm getting to my point, I promise. Those women will come to us and their metabolism and their metabolic and inflammatory markers look like a menopausal woman. So they're young. They might not even be overweight, but their cholesterol is up, their CRP is up. They look ill because...
Sorry, what is CRP?
CRP is C-reactive protein. So it's an acute marker of inflammation. It will be high, like if you have COVID or if you have an infection, but it can also remain elevated due to chronic inflammation.
Okay.
So they will look, even at 28 years old or 30 years old, they'll look like a menopausal woman in their labs. If you replace their hormones to physiologic levels and you start cycling them and help them to get a period and give them, you know, a hormonal milieu that looks like a healthy cycling woman, all of their metabolic markers will improve and reverse, and they become unpre-diabetic. We've seen this in multiple case studies. However, in a menopausal woman, if you do the same thing and you replace her hormones to a physiologic level, we still see metabolic markers improve dramatically, but not have the same level of improvement as in younger women. So there is an independent aging that happens to the metabolism, right? Yeah. Meaning it happens independently of estrogen loss, but it is greatly accelerated by the loss of estrogen, right? There's a fire going, and loss of estrogen just adds so much fuel to that fire.
Okay. Right? That's a great analogy.
Both things are important. Like we have to address metabolic aging as an independent thing, and we also have to address hormone decline. Now, coincidentally, addressing hormone decline helps every body system, not just the metabolism. Right. But I always want to be clear for women that, like, for some, just replacing hormones will totally fix your lipids and may help you with weight gain. But like most women don't experience a total transformation in their metabolism just from starting HRT, no matter how good their HRT protocol is.
So are there lifestyle things that menopausal women can do to help with the weight gain or decrease the weight gain?
Yes, absolutely. And it's a great segue because one of the points I love to make is that while the introduction of hormones alone don't necessarily reverse all of the metabolic aging, they help you do the lifestyle things that will help you with the metabolic aging better, like getting great sleep, right? Having, like, you know, as simple as it seems, it's one of the most effective things is love and connection, right?
Okay.
You're a lot more loving, a lot more likely to want to be connected if your hormones are replaced and you're making adequate levels of neurotransmitters. You're much more likely to want to exercise and move your body. You're much more likely to want to make really good food choices and to care, right?
Yeah.
A lot more. Like, this stuff is important, right? It's really important for me when we first start working with someone that someone just starts to feel better and they feel like they have the energy and the drive to go do these other things. Like, it's really, I think, cruel to take a very, very perimenopausal or menopausal woman and be like, you need to radically change your diet and you need to get more sleep and you need to be off screens and you need to X, Y, Z, because, you know, any woman in perimenopause or menopause, like, they are already working their butt off, right? They've been working their butt off for the last 20 years. They've been raising kids. They've been like growing their career. They've been taking care of a whole family, maybe taking care of aging parents. Like, the last thing they need is to be like, you have to do 10 more things in order to like feel better. It's like, I really want to have a more additive approach with women than reductive, meaning like I want to pour into you so that it feels like good to go do this next thing, right? And it feels good to like maybe make different food choices, right? So on the things that you can do, like to sort of improve metabolism, one of the most important things is adequate protein and adequate fiber. That's where we start with every woman, because again, it's an additive approach, not reductive.
Right.
And it can be amazingly effective at not only affecting your cholesterol level, but you know, changing fat deposition, helping women to lose weight, to help them get adequate protein. So, you know, 100 grams is a really good baseline marker. Now we could get really specific on that based on your activity and your body size and sort of your target weight. But let's just say, for the purposes of this interview, 100 grams is a really good marker, and most women are getting 40 to 50. That I mean,
100 grams of protein.
Yes, per day. Grams of protein per day. And fiber, our ancestors, like our prehistoric ancestors, right, were getting 100 grams of fiber a day, right? All we ate was fiber. Yes, literally. And we just, you know, it's impossible to get, people are getting like five to 10 maybe now. If you're eating any processed foods, you're probably getting 5 to 10 grams of fiber. So we like to try to get people to get 30 grams of fiber, which is not easy, right? You have to eat a lot of plants, and you have to be intentional about adding things in, like pumpkin seeds and beans and certain grains that are really high in fiber. So that's super important. Starting there can help tremendously. It helps with satiety, meaning how full you feel.
Right.
It helps with elimination. It helps with liver detoxification. And then I think about things like eating foods that are rich in polyphenols. So green tea, I'm a huge fan of matcha. Some people either hate it or love it. If you're a hate it person, that's okay. We can find other sources of polyphenols. Berries, like things that are dark and rich in color, right? So blackberries, blueberries, raspberries, you know, certain nuts, walnuts, pumpkin seeds, pomegranate. All of these things are really, really rich in antioxidants, right? So they help to dampen that inflammatory response that's happening as a natural response to aging. So I'd say those are really basic things. But again, sleep is so important. That's like, these are the first places that I start. And I like to say, like, I think in a setting like this, in a podcast where someone's just popping in, let's start with like the easy low-hanging fruit, right? Increasing omega-3 fatty acids is also really helpful. So taking a fish oil supplement, eating sardines, fatty fish, things like that is really, really helpful for inflammation.
What if you're vegan?
That's a hard one for me. I mean, I think, to be totally honest with you, it's very, very, very hard if you're even a vegetarian, but especially a vegan, to get macro composition right and micronutrient composition right for a pro lean muscle mass and, you know, low visceral fat scenario with a vegetarian or vegan diet, because you have to eat so many carbohydrates in order to get the protein that you can put yourself into kind of a blood sugar storm. It's really, really difficult. I think it can work for some very specific genetic types, but in most cases, if someone is willing at all to consider animal protein, it's really beneficial in terms of building lean muscle mass. And if weight loss is a goal, right, it's incredibly helpful.
Yeah. Okay.
I want to shift to something else that you mentioned about thyroid. I feel like, at least with some of my clients, in the 40 to 50 age bracket, they're starting to have thyroid problems, and every other woman seems to have thyroid issues. why is this connected also to menopause?
Yeah, there's actually a connection between particularly progesterone and T3. So that's the active thyroid hormone, that T4, which is the primary thyroid hormone that gets tested, gets converted into, that's more active at the tissues and that we're really concerned about with thyroid insufficiency is T3. So as progesterone declines, right, that there's a bidirectional relationship between T3 and progesterone. So that can be part of it. But there also is a term called thyropause. So there is sort of an independent sort of thyroid aging that can happen. You know, thyroid gland, just like all the endocrine glands, also is very sensitive to our environment. It's very sensitive to toxins. It's very sensitive to micronutrient deficiencies. So depending on the thyroid presentation that we see, there's oftentimes a lot of things you can do from a lifestyle and nutrition standpoint to improve thyroid output. But yes, it's true. Like we do have many women on also thyroid medication, but it's also really important to look at what's causing the thyroid insufficiency. We always test thyroid antibodies in our practice on everyone. Even if you were to have normal TSH and normal T4 and T3, we want to screen for Hashimoto's, which is an autoimmune thyroid disease, where you're making autoantibodies that are attacking your thyroid tissue. And what we know is actually even 10 years before the appearance of antibodies in the blood, we know from biopsy that there are changes to the thyroid. So meaning that like if you have Hashimoto's, it's there, you know, even up to 10 years before we even see it on labs. And there's a lot that you can do from a diet standpoint to try to dampen that autoimmune response, the sort of hyper reaction of antibodies, you know, to the thyroid and slow the destruction of the thyroid gland. So it's not as, you know, cut and dry as like if you have a thyroid issue, you need thyroid replacement. There's like, it's a multifactorial thing.
Wow. Like it's so intense.
I thought it was connected, but to have a name like thyropause, that's
crazy. It's really important that like we're screening for the whole thing. Like it drives me nuts that even, you know, my parents who are in their 70s go to their primary doctor and he just runs a TSH. And I'm like, for the love, because TSH is a brain hormone, right? It's just a pituitary hormone. And it should respond, right? In theory, it's a feedback loop. So if thyroid levels are low in the body, TSH should go up. But there are other reasons why TSH can be high. TSH can actually be high, even if T4 and T3 are normal, if there's thyroid inflammation. So you could have high TSH, you know, say of 6, 7, right? Should be like typically less than 3, a TSH could be really high. And your doctor will put you on Synthroid, which is a synthetic T4. And it doesn't make you feel better because if you were to actually look at your labs, you have positive antibodies, normal T4 and T3, and your treatment should not be Synthroid. It should be an autoimmune, you know, therapeutic approach with supplements and diet to lower that autoimmune response, and that's going to decrease the thyroid inflammation, but actually giving you T4 is going to make you feel worse. So it's really important that you have the whole thyroid evaluated.
Oh my gosh. And you have to fight for that.
Yeah.
Like if I go, I want my whole thyroid, they're going to be like, you just did. I did it. I did your TSH.
Right.
Like, then I'm like, oh, okay. And I come home and I feel like this, like, do you know what I mean? Like it's this.
Yeah, no, I do. I mean, I think that we want so badly, like a bad relationship for the conventional medical system to meet our needs, you know, but it's like everybody has that friend Mary that's been married to the asshole for years. And you're like, Mary, like your problems aren't going to get better as long as you stay married to Rich. Like, I'm sorry.
Yeah.
It's just like, we're all tired of hearing about it. And I kind of feel that way about conventional medicine. Unfortunately, I think that, you know, it's good to have commercial insurance. It's, you know, great to occasionally like get an opinion or input from someone, but we really have to take up the torch and ownership of our own health. And there's so many ways. There's no excuse anymore because there's so many ways to go get your labs done. My practice offers a way for people to just get 58 biomarkers done, which is probably 3 times more than you would get at a conventional doctor's office, and an hour-long visit interpreting all of the labs. You can do this with Function Health, which I mentioned before. You can there's a million ways to get your own labs done now. But
I didn't know that either.
Yeah.
I had no idea.
Yeah, I mean, we just have to take ownership, right, for ourselves. And, you know, the information is out there, right? It's just that I think there's a grieving of like, man, I really wish that like this insurance that I've worked so hard to get or the system that like is out there for me would work for me. And unfortunately, it just doesn't, you know, in most cases.
I was going to say that I think a lot of times, I think I come back to that point of women are gaslit. Like, this is so fine. This is normal. It's fine. I don't know what you're complaining about. And instead of saying, yeah, let's just run these full battery of tests, insurance doesn't cover it. So we're not going to check it. And your basic numbers look fine. So just take this medication and you're on your way.
Well, I want you to remember too, that OBGYNs and even WHNPs like myself, 80 to 90% of our education has to do with prenatal care and pregnancy and delivery. Like, we
80%.
value women for their ability to reproduce. Think about how much science,
Wow.
how much testing is done in reproductive endocrinology and IVF, right? Sometimes those are actually the doctors that know the most about hormones. And was sort of the reason why those monitors I mentioned at the beginning of the interview, the Mira and the Anito, were developed. They were developed because, and REIs use them, right? People on an IVF journey or a fertility journey use those monitors. So once we have given birth, society as a whole is not valuing women, and it's not valuing our well-being by any stretch of the imagination. And the wild thing about that is that, like, most women's careers take off after they're done childbearing, right?
Yes.
Most women entrepreneurs start their businesses after they're done childbearing. They're contributing to society in major ways, and their well-being, their brain power, their stamina, their energy are all directly tied to how they feel. Right. And
Exactly.
our productivity, right, the economy really depends on midlife women being well. But the medical system is still really set back in time. And we're just not teaching people on, midlife health. Like, it was a very small portion of my education. And I know it's the same for OBGYNs, even less so. And hospital systems aren't investing in it either, because it's not where they get sued. So the most, like, continuing ed that providers get is really, like, for risk mitigation, right? So that if they practice birth still or GYN, they're going to be getting lots of education on, like, how to do this safely or do this safely so they're not getting sued, right? There's also not a lot of drug innovation in the menopause space, meaning that, like, pharmaceutical companies aren't developing, like, new hormones. All these hormones, estradiol, progesterone, the bioidentical forms, are generic now, right? They've been around forever. And so, like, no one stands to profit off of research and innovation in menopause, right? So it really has to be, like, a government funded thing where, like, we value as a society understanding this phase of life better and pouring money into research that we have better information to go from.
Well, it actually seems counterintuitive to me, because if you're a woman at this stage of life, you've raised your children, you've you've finished most of your responsibilities, you have independence now, maybe a little bit of financial freedom to do what you want, and then suddenly you don't feel good. So it's sort of a weird mix or a crossroads of life, that suddenly you have space, but now you're just stuck with not feeling good. And many women feel that they don't get the help, or they don't understand what's happening to their bodies.
Right.
Yeah.
Wow.
We are currently in 12 states, and you can list those in the show notes for people. And you can either start by just, scheduling a free consult with our team, speaking to one of our health coaches about what it looks like to work with us, or you can just start with getting a full panel of labs and a 1-hour visit, right? Anybody can do that. That's $5.95. And we can even give a $50 discount to the people who listen to this podcast. So we'll put a code in the
Does do HSA cards or flexible spending take those?
Sure do.
Okay.
Yep. And we do all of our labs. We decided to stop working with insurance a few years ago for lab work, just because, just like everything in the system, everything had to be justified and sort of fought for and argued against. And, we're able to get sort of negotiated cash prices for labs and have a lot of transparency, which is super helpful. And I even do that for myself. I use cash labs because my insurance is through a hospital system, because my husband's a physician, and, like, we just get crazy bills. It's like, you just never know, like, what you're going to get. And I think we're in a new era of healthcare where people really value, like, integrity, transparency, and are just looking for something that's a more complete, care experience. And that's really what we strive to offer.
That's awesome. I love that.
Yeah.
I feel like we didn't even touch the tip of the eye. Thank you so much.
Thank you so much.
It's my pleasure.
We hope you enjoyed today's episode. All the information provided is meant for education and entertainment purposes only. Please consult your physician before making any changes.
If you liked this episode, please give us a 5-star review. Also, share this episode with someone who you think would enjoy it. If you have topics you want us to investigate, please message us. Thanks!